Assalamu alaikum. This is Dr. Mariam Al-Abdallah, a professor in orthodontics and a senior orthodontic consultant. This is a second lecture that we're going to continue talking about the cephalometry. And again, it's the same reference, chapter 6 from An Introduction to Orthodontics, 5th edition, Laura Mitchell and Simon Littlewood. If you remember, we talked about the cephalostat when we said there is a specific standardization for the process of taking the lateral cephalogram in order to be able to compare different radiographs for different patients or for the same patient, radiographs taken for the same patient at different times. And this is the end result of the radiogram. And we usually start by tracing the soft tissue outline, bony outline, then identification of points, and then after that we connect the points to form planes, and then we measure angles and lines, and we end up having a certain analysis. So just to review what we talked about last time, the references. So the first one here is at the most anterior part of the frontonasal suture, which is the Nasian, exactly here. And then we have a point that represents the center of the sella torsica, exactly here. And then we have the point that represents the most inferior anterior part of the orbit, which is called the inferior orbitale. And then we have, this is the head of the condyle, and this is the ring that you see here is the ear rod. It's not always actually comes exactly in the middle of the external auditory meatus. So here is the external auditory meatus, this round structure here. The uppermost part of it is the porion. Now next comes the most anterior part of the maxilla, ignoring the cartilage of the nose. Exactly here is the anterior nasal spine, and the most posterior part, guided by the pterygomaxillary fissure, is the posterior nasal spine, exactly here. And then we have the deepest concavity of the anterior surface of the maxilla. It's exactly here, that represents the A point. And then we have the upper incisor edge, upper incisal apex, lower incisal edge, lower incisal apex. And then we have the deepest part of the anterior surface of the mandible, that is the D point. The most prominent part of the symphysis, and that's the abegonian. The most inferior part of the symphysis, and that's the menton. And in between the most inferior anterior part is the gnathian. And then a point that represents the angle of the mandible, in specific represent the most inferior posterior part of the mandible, is right here, where we take the average between these two lines. And after that, we have the articulary, which is imaginary point that represents the junction between the basilar part of the occipital bone and the posterior part of the head of the condyle here. And then the end part of this is the basian, and the basian represents the most anterior part of the foramen magnum. Right, so these are the main points that we talked about last time, and this is a drawing that shows the soft tissue outline, bony outline, and some of the points that we talked about. When we connect sella to Nasian, we will have the cranial base. So the sella Nasian represents a line that connects S point to the Nasian point. Frankfurt horizontal plane is a line that connects porion to orbitale. Mandibular plane is a line connecting gonian to menton. Maxillary plane is a line connecting the anterior nasal spine with the posterior nasal spine. The functional occlusal plane represents the maximum intercuspation in the posterior segment, including the first permanent molar, the premolars, ignoring the incisors, ignoring the overjet, the overbite, and ignoring the sevens. So it's a line that represents the maximum intercuspation between the upper and the lower teeth. Upper incisor long axis is a line that connects the upper incisal edge with the upper incisal apex. Lower incisor long axis is the line that connects the lower incisal edge to the lower incisal apex. So these are the most important 7 lines that we need to construct after we identify our point. So again, these lines you need to extend as long as possible because these lines should meet, and then you measure certain angles in between. So this is the SN line, which is the cranial base. This is the Frankfurt plane, which is the Porion orbitale line. And this is the maxillary plane connecting the posterior nasal spine with the anterior nasal spine. And this is the mandibular plane connecting the gonian to the menton. This is the long axis of the mandible. And this is the long axis of the maxillary incisor. So this is the long axis of the mandibular incisors, and this is the long axis of the maxillary incisors. Right. So the upper incisors is a line connecting the incisal edge and the root apex of the most prominent maxillary incisor. The lower incisor line is a line connecting the incisal edge and the root apex of the most prominent lower incisor. So if you have crowding and you have incisors that some are procline, some are retrocline, then we take the most prominent incisor. Right. Now, the measurements that comes out as a result of our analysis should be compared to what we call norms, cephalometric norms, which means the normal values for a certain ethnic group. Eastman standard are the cephalometric norms for Caucasians, only Caucasians, okay? So each measurement, you have the mean value plus minus standard deviation, 3. So this is the mean value, and then we have range of acceptable values plus minus 3, and so on. We will talk about these values. The same for the Jordanian population. We have, compared to the Eastman standards, we have Jordanian standards. Again, same measurements, but numbers not far away from the Eastman standards, but a little bit different. We also have a little bit different standard deviation. So if your patient, for example, is Afro-Caribbean, it's important to go and compare the values for your patient to the Afro-Caribbean norms. It depends, the norms depends on your patient's ethnic group. It's important to plan, diagnose the case, and aim to reach the normal values for the specific ethnic group for your patients. Right, so after we finished tracing the outlines and identifying the different points and forming planes, now we need to measure angles after we get something that looks like this on our tracing paper. Now, in order to move to our analysis, we're gonna divide them into 3 components: the anterior-posterior skeletal pattern, the vertical skeletal pattern, and then dental relationship. The anterior-posterior skeletal pattern consists of the A and B angle, which is part of the Eastman analysis, Bayesian perpendicular, Pollard conversion, and width analysis. Okay. A and B angle. The A and B angle, we don't actually measure it, but we calculate it. What does that mean? We need to measure the SNA, which is the angle between the cranial base and the A point that represents this angle should represent the anterior-posterior position of the maxilla in relation to the cranial base. So we measure this angle exactly here, and we compare the value, the resulted value, to the mean, 81. So if your patient scored 84 or 85, that means that the maxilla is prognatic. If your patient scored, for example, 81, that means the maxilla is occupying a normal position in the anterior posterior dimension in relation to the cranial base. If your patient scored 77, for example, for the SNA, that means that maxilla is retrognatic. The same for the SMB. So the SMB, this angle here, SNB, this angle here, represent the anterior posterior position of the mandible in relation to the cranial base. If it's average, that means the patient has normal anterior posterior position of the mandible. If it's increased, that means the patient has prognatic mandible. If it's reduced, that means the patient has retrognatic mandible. A and B equals SNA minus SMB. Okay, so for example, 81 take away 78 is 3. 2 to 4 is considered the average. What does that mean? That means the maxilla and the mandible are occupying normal skeletal pattern, which is class 1. If the A and B is less than 2, it could be 1, 0, minus 2, minus 4. It could be, we can have a minus value. Okay. For example, if the SNA is 85, the SNA, let's say 80, and the SNB 82, that means the A and B is minus 2 because it's SNA minus SNB. So 80 minus 82 equals minus 2. Minus 2 means that the patient has a class 3 skeletal pattern. Any value of the A and B above 4 means that the patient has a class 2 skeletal pattern. So this is how we use A and B angle as part of Eastman analysis in order to evaluate and diagnose the skeletal pattern in the anterior posterior dimension. So again, the SNA represents the anterior posterior position of the maxilla in relation to the cranial base. The average is 81 plus minus 3. SMB represents the anterior position, position of the mandible in the anterior posterior dimension in relation to the cranial base. The average is 78 plus minus 3. A and B is the angle between the A and B, but we don't measure it because it's very small and there is some error associated with this. We calculate it, so it's SNA take away SMB, and this is equals a certain number. The average is 3 plus minus 1, so it's 2 to 4. That is considered class 1. Now, the disadvantages of Eastman analysis using A and B angle is that it assumes that the cranial base is stable, and it studies the anterior posterior position of the maxilla and the mandible in relation to the cranial base, when actually there are some changes in the end point vertically and horizontally with growth. It might change its position. In addition, the A point and the B point are assumed to represent the anterior posterior position of the maxilla and the mandible, when actually these points sometimes could be modified in response to tooth movement. So maybe they are not a strong indications of skeletal relation. Finally, it's difficult to identify A point. It's easier to identify B point. So we will have some error, and the reliability of the measures will be questionable. In order to reduce such error, we have what we call Eastman correction. Eastman correction. In order to be able to apply Eastman correction, we need 2 conditions to be met. Number 1, SNA should not be equal to 81. So if your patient, the SNA scored 81, that means Eastman correction is not applicable. We cannot apply it. The second condition is to have the angle between the cranial base and the maxillary plane with an average, which is 8 plus minus 3, which means 5 to 11. If SN maxillary plane angle scored average 5 to 11, that means we can actually apply Eastman correction. If it's above 11 or below 5, we cannot apply Eastman correction. Eastman correction is not applicable. Now, if both conditions were met, how can we apply Eastman correction? If SNA for my patient is increased, is more than 81, then for every degree that SNA is greater than 81, we subtract half degree from the calculated AMB. Vice versa, if SNA that is measured for my patient is reduced, less than 81, then for every degree that SNA is less than 81, we add half degree to the AMB. This is an example. So these are the measures for a patient. SNA is 83, SMB is 77, AMB is 83 minus 77, which equals 6. Given that the SN maxillary plane angle is within average and SNA is not equal to 81, then we can apply Eastman correction. For each degree SNA is above 81, we subtract half degree. So for this patient, the SNA for the patient is 2 degrees above 81. That means we need to subtract a whole degree from 6, which means that after correction, A and B equals 5. Okay, 6 means class 2 skeletal pattern. 5 means more class 2 skeletal pattern, but less severe. And this diagram here, just to show you, if endpoint due to growth has changed its position horizontally, then the angles, if it becomes more anteriorly, for example, then the SNA angle and the SNB angle will be reduced. So if the patient continues to grow with the cranial base forward, for example, then the angles will reduce like this, and you will end up having an A and B of 4, which means that the patient has class 1, when actually the maxilla and the mandible did not change their anterior-posterior position. So these are some of the disadvantages of this analysis. The second analysis is a MacNamara analysis. It is called Bayesian perpendicular, and it is based on a perpendicular line dropped from the end point, as you can see here, from the end point on perpendicular on the Frankfurt plane, And on average, we need to measure the distance from A point to this line and the abegonian to this line. To be average, to be called a class 1, A point should be on or slightly ahead of this line, so 0 to plus 1, and the abegonian should be -2 to plus 4, so around this line. If A point is scoring more than this, that means we have prognatic maxilla, and vice versa. And if abegonian is scoring more than this, that means we have prognatic mandible, and vice versa. Okay. So just to show you, this is the end point. We drop a perpendicular line to the Frankfurt plane, and Frankfurt plane, if you remember, is a line between the inferior orbitali and the porion. And then as it drops down, we look and we study its relation to A point and abegonian. The third measurement is Pollard conversion that was introduced by Pollard in the 1948. And it allows to study the skeletal discrepancy in the anterior posterior dimension by looking at the position of the incisors after conversion. What do we mean by conversion? Any patient that has a skeletal discrepancy plus favorable soft tissues, then the soft tissues, the tongue, the lips, the cheeks, will try to mold the position of the teeth in order to reduce the severity of the underlying soft tissues. So, for example, for class 2 patients, the soft tissues, if favorable, they usually try to retrocline the upper incisors and procline the lower incisors to reduce the severity of the malocclusion. And the opposite is true for class 3 malocclusions. Okay, so Bollard's conversion is based on removing such soft tissue influence on the dentition. How? By bringing the upper incisor to the average angle with the maxilla and bringing the lower incisor to the average angle to the mandible, but average in relation to the maxillomandibular plane angle. So the upper incisors should be moved so that the angle here, we rotate them around the apical 1/3 of the roots until the angle is 109. And for the lower incisors, we use this formula, 120, 20, take away the maxillomandibular plane angle for that patient. We measure the angle between the maxillary plane and the mandibular plane. And then we use this formula, 120, take away the angle, maxillomandibular plane angle. And then we tip the lower incisors around the apical 1/3 until we reach to this ideal angle that we calculated. When we finish, we measure the residual overjet, which is considered the real overjet for that patient. If the overjet is 2 to 4 millimeters, that means the patient is presented with a class 1 skeletal pattern. If it's more than 4, that means the patient has class 2 skeletal pattern. If less than 2, that means the patient has class 3 skeletal pattern. So, for example, if the patient has maxillomandibular plane angle of 20, that means 120, take away 20, 100. That means we need to move the lower incisors until the angle here is 100, and we rotate the lower incisors around the apical 1/3. The upper incisors, we change the angle until we reach to 109, which is considered the average. And then we measure the overjet. The overjet is the horizontal relationship between the upper and the lower incisors, measured from the labial surface of the lower incisors to the incisal edge of the upper. Finally, width analysis that was introduced by Jacobson in the 1975 is based on the functional occlusal plane. So this is the functional occlusal plane. We drop perpendicular to this line from the A point, and we drop a perpendicular from the B point to the same line. And then in females, it should be almost 0. They should be coincident. This is for females. And for males, usually it's at -1. The A perpendicular is usually behind the B perpendicular. This is the average, okay? Now we come to the vertical skeletal pattern. For the vertical skeletal pattern, we can have 4 measurements. The angle between the maxillary plane and the mandibular plane, the maxillomandibular plane angle, Frankfurt mandibular plane angle, anterior lower facial height, the ratio between the posterior facial height and the anterior facial height, which we call Jarabak's ratio. Right. So this is the maxillary plane. It's the line connecting the posterior nasal spine and the anterior nasal spine. We extend it all the way back until it meets the mandibular plane. And then this angle here, we measure this angle, and it's supposed to be 27 ± 4. If it's more than that, that means the patient has a tendency for posterior growth rotation. If it's less than that, that means the patient has a tendency for anterior growth rotation. And it measures the divergence of the intermaxillary space anteriorly. Right, this value is largely determined by the ratio of anterior and posterior intermaxillary height. Frankfurt mandibular plane angle could be measured or could be assessed, not let's say accurately measured clinically, but clinically we can assess it because Frankfurt plane, we have clinical references. Mandibular plane, we have clinical references. But this is not true for maxillary mandibular plane angle, because maxillary plane, we cannot determine this extraorally. So Frankfurt mandibular plane angle could be measured or assessed extraorally, and it could be measured intraorally. So this is the Frankfurt plane, and this is the mandibular plane, and this angle here represents the Frankfurt mandibular plane angle. It should be 28 on average, plus minus 4. Anterior lower facial height is a ratio between the lower facial height to the total of the anterior facial height. How do we measure it? The reference is the maxillary plane. The maxillary plane is the base, is the reference. We drop perpendicular from end point to the maxillary plane, and we drop perpendicular from menton to the maxillary plane. We measure this line, the end maxillary plane, and the menton to maxillary plane. Then we use this formula. The measurement down here, which is the maxillary plane to the menton, divided by adding these two together. The maxillary plane to the menton plus maxillary plane to nasien, multiplied by 100%. So here, for example, 70 over 75.5 plus 70, which is about 55%. And 55% is considered the average value. This is considered the normal. So again, this is the upper anterior facial height, and this is the lower anterior facial height. This is the maxillary plane. We drop perpendicular from the end point. We drop perpendicular from the menton. Adding these two measurements together is called the total anterior facial height. And if we divide the lower anterior facial height alone to the total anterior facial height, this is called the anterior lower facial height ratio. For example, for this patient, it's 53.3, which means that slightly reduced lower facial height. The normal is 55%. Jorabach's ratio is the ratio between the posterior facial height and the anterior facial height. So we take the total of the anterior, and we take the posterior facial height, which is measured from the sella to the gonian. So this line here, from the sella to the gonian, and then we put it up here, and we divide it by the total anterior facial height. And then we have a certain number. More than 65% indicates a forward growth rotation. Less than 62% indicates backward growth rotation. In between indicates average normal growth rotation. Now we come to the incisors position. To be able to assess this, we can measure the upper incisor long axis to the maxillary plane to check the orientation of the upper incisors, the inclination of the upper incisors. Then we measure the angle between the lower incisor long axis to the mandibular plane to check the lower incisors inclination, and then the interincisal angle, which is the angle between the upper incisor, the long axis, and the lower incisor long axis. We can also assess the lower incisal edge in relation to abegonian line. And then we can have what we call prognosis tracing. So first, upper incisor to maxillary plane angle. This is the upper incisor long axis. This is the maxillary plane. This angle right here This angle here, we measure it, okay? And on average, it's 109 plus minus 6. So more than that is considered proclined incisors. Less than that is considered retroclined incisors. If it's within average, within this range, it is considered of normal inclination. The lower incisal long axis to the mandibular plane, on average, it's supposed to be 93 plus minus 6. Again, if more proclined, if less retroclined, if average within this range, it is of average inclination. Sometimes we look at the relationship between the lower incisal orientation and the maxillomandibular plane angle using this formula that we used for Pollard's conversion. 120 take away the maxillomandibular plane angle. This should equal to the normal lower incisal inclination for that specific patient. So there are two ways to look at the normal for a specific patient. The interincisal angle is the angle between the upper incisal long axis and the lower incisal long axis. So this angle here, it should measure 133 plus minus 10. If there is contact between the upper and the lower incisors, then this angle is important, especially in class 2 cases. High angle usually is associated with deep bite. Not for necessary, but usually it is associated with deep bite. If during treatment the overbite was reduced, then it's very important to normalize this angle for stability. Abegonian line that was introduced by Williams is the distance between the incisal edge, the lower incisal edge, and the abegonian line. Okay, I think this is not true. It's the lower incisor, not the upper incisor. It's the lower incisal edge to the abegonian line. Okay, the lower incisors in a well-balanced space with good occlusion, the lower incisor should be at or slightly ahead of the abegonian line. So it's a 0 to 2, the normal for the lower incisal edge. It is not used to predict stability. It's mainly for aesthetic. Prognosis tracing means to mimic the planned tooth movement on a tracing paper. So for example, here, I have a huge overjet. I'm planning to reduce the overjet by bodily movement of the incisors backward. So I mimic this movement on the tracing paper. And as you can see, this is not possible. This movement is not possible because the whole tooth will move outside the boundaries of the bone. So I need to come up with another plan. Okay, so this is used for treatment planning, and it tests the feasibility of tipping bodily movement within the bone anatomy constraints. And it's like we have a rough guide. If you change the angle of the incisors by 2.5 degrees, that means that in the anterior posterior dimension, they will change in about 1 millimeter. So if you retrocline the upper incisors 5 degrees, that means the incisal edge has moved backward 2 millimeters. Just a rough guideline, okay? And then we look at our planned treatment. Is it possible? Is it feasible? Is it realistic or not? Now, finally, in terms of soft tissue analysis, we look at 3 lines. Hold away line. Hold away line. By the way, the 3 lines end up at the anterior part of the chin, the soft tissue abegonian, okay? The first line is from the chin to upper lip. This is starting from the chin to the upper lip. This is the hold away line. And in a normally balanced face, it should bisect the nose. Like here, it should bisect the nose. Ricketts E-plane is a line again from the chin from the chin to the nose. and then the lower lip should be positioned 2 millimeters ahead of this line, and the upper lip should be at or slightly behind this line. So for example, for this patient, both upper and lower lip are behind this line, so the patient has retrusive lips. Facial plane is a line that extends from the chin again to the nasion, to the soft tissue nasion. Okay, so soft tissue abegonian, soft tissue nasion, and then we measure the angle of this line with the Frankfurt plane, and it should measure about 86 degrees in a balanced face. So these are the most important 3 soft tissue lines that we can use for our patient's analysis. Now, assessment of growth and treatment changes, I think we need to cover this in our next lecture. So in our next lecture, we're going to talk about how we compare different radiographs to look at changes due to growth or due to treatment and tooth movement. We will talk about the errors with the cephalometric analysis, and we will take a few examples on the analysis and interpretation of radiographs. Thank you for listening.